Hello everyone. Well, welcome to all of you. And now I'll be discussing latest previous year's questions of medicine. I have a suggestion for you. A question will come to you. You read the question and try to answer the question. And if you want, you can even stop the video to read the question. In that way, your understanding will be much better. So let's talk about question number 1. Which of these is not the feature of fetal alcohol syndrome? Well, the right answer is wide head. There are 3 characteristic facial features of fetal alcohol syndrome. And these are, number 1, smooth philtrum. That is flattening of groove between nose and the upper lip. If you can keep your finger on this part where I am keeping, this is the philtrum, and this becomes smooth. We all have some groove, but in that case it becomes total flat. Thin vermilion, the upper lip is thin. And the third one is small palpebral fissure, eyes width decreases. Okay, so these are the 3 classical features about FAS. Now there are certain other features also. Skin fold at the corner of the eyes, low nasal bridge, short nose, indistinct philtrum groove between nose and upper lip that I discussed in the previous slide also, small head circumference, small eye opening, small mid face, okay, and thin upper lip, the point we discussed in the major criteria also. That they are a feature which are seen in this particular picture also. Let's talk about question number 2. Initiation of puberty is due to which of these organ? Options are in front of you. Try to answer the question. Well, answer is brain. Why? Because gonadotropin releasing hormone GnRH, this comes from hypothalamus, and it is this hormone it control puberty. Puberty is the onset of secondary sexual character. Well, onset of menarche in female and same thing in males. This facial hair, etc. All are the secondary sexual character. But this is released in a pulsatile fashion. And hypothalamus neuron, they cause changes in the puberty. Well, if I have to tell you a beautiful picture, neuroendocrine control of puberty, right, sir? So let's look into this. This is CNS and this is the hypothalamus, which I talked to you. Hypothalamus. It is this one which is secreting GnRH, that is gonadotropin releasing hormone. Of course, there are many other hormones are also given, but at the moment I am just focusing on what I need about this question. So this lead to FS, LH and FSH. And it is this one which is going to act on the gonad. So the point to focus are hypothalamus, GnRH, LH, FSH and gonads. So now in a simple one-line diagram, you can see beautiful things about the puberty. So hypothalamus, GnRH, and this is causing LH, FSH, and this is acting on the gonads and causing all the feature of puberty. Question number 3. You are getting a 68-year-old patient. He come to you with BP of 190 and diastole of 100. So BP is 190 by 100. It's a very high BP, definitely. Heart rate is 74, it is normal. The wide pulse pressure is due to decrease in which of the following factor? First of all, we understand what is pulse pressure. pulse pressure, which we write in PP also. Okay, the pulse pressure is systole 190 minus diastole 100. The pulse pressure here is 90. Normal pulse pressure is around 30 to 60 millimeter mercury. But here we are getting more of a much more than the normal. And one more thing, you can see systolic BP is very, very high. Well, if you have to look into this, you need to have just focus on this age, 68 years. Well, before I discuss the question, let me tell you something very important. In elderly people, sometimes we get isolated hypertension. Seen in elderly people. Sometimes you get a patient of elderly patient having BP of 190 or maybe 180 by 70. So we are getting only systolic hypertension, diastolic is normal. This is isolated systolic hypertension. In this case also, of course, this is not isolated because even diastole is very high. So what is the reason why we are getting more of a systolic hypertension? And same thing happen in isolated systolic hypertension. This is due to arterial compliance. So in elderly person, what happened? This artery, it becomes thickened, and I'm sure if I ask you what are the cause of this thickening of the arterial or reduced compliance, okay, try to write down what is the basic pathology by which compliance is reduced. Write down the answer in your copy. I'm sure by now you may have written the answer. Answer is arteriosclerosis. Quite possibility that you may have written atherosclerosis. It's not athero. In arteriosclerosis, it's a tunica media. You all know very well in the artery, aorta, there are three layers, intima, media, and externa. Atherosclerosis is the problem of intima. Arteriosclerosis is the problem of media, tunica media. And that's why arterial becomes stiff, they lose the elasticity. So that leads to decreased compliance of the large elastic artery, typically aorta. And that's why systolic BP increases. And this loss of elasticity is due to decreased elastin content, increased collagen deposition and calcification, which occurs in tunica media, as I told you, and that leads to increased stiffness of the arterial wall, and that's why systolic hypertension increase. So now left ventricle contract against the stiffer and less compliant artery, causing increase in systolic, mainly systolic. Diastolic pressure is not increased much. Of course, in our case, diastolic is also increased a little bit, but remember, primarily it is systolic hypertension. Diastolic a little bit. Anyway, that leads to wide pulse pressure and left ventricle hypertrophy occurs. This is hypertrophy occurs secondary to long-standing hypertension. So I think you can read it now very comfortably. So in nutshell, the answer is arteriosclerosis due to tunica media involvement, not tunica intima. Question 4. ESR is raised in pregnancy. Okay. And this increase is due to what? What is the basic reason? There are 4 options given, A, B, C, D. Why ESR increases in pregnancy? Well, I'm sure you have done the answer is fibrinogen. As a result of increased fibrinogen and globulin level and decrease in blood viscosity, ESR increases 4-fold during pregnancy. Next, question number 5. Well, endocarditis prophylaxis is not required in which of the following condition? This is a very, very important question, and this question practically comes in all the exam. Okay, so definitely is going to come to you also. So in a lighter way, I say I'm leaking the paper to you. Well, okay, well, the right answer is CABG. Now, there are certain changes has occurred as compared to previous one. The latest guidelines indicate this. So remember, I'm talking about latest guidelines. We need prophylaxis in following condition. A prosthetic valve or who had a heart valve repaired and with prosthetic material. History of endocarditis. Heart transplant with abnormal valve function. Certain congenital heart disease that includes cyanotic congenital heart disease. Okay. That does not fully require children who have had a surgical shunt and conduits. So you can say in nutshell, if I have to give you a summary of this line, cyanotic congenital heart disease. This much you have to remember it. Then congenital heart disease that has been completely repaired with prosthetic material or device for the first 6 months after the repair procedure. But one thing is very clear, if prosthetic material has been used, then that patient definitely needs prophylaxis. Repaired congenital disease with residual defects such as persistent leakage in such cases. If I have to simplify the subject, this point number 5, 6 and 7, just remember this thing. If you remember this much, this is good enough. Any congenital heart disease or prosthetic material we are using. Okay, now let me add something. Previously, we were using for mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation. The recommendation were for valvular heart disease, but now the new guidelines say this is not needed much in these cases. So in nutshell, only one line. So 2 lines, number 2, number, any congenital heart disease, especially cyanotic congenital heart disease, okay? And even they say even ASD, VSD also, or PDA is not that necessary. So cyanotic congenital heart disease, number 1, and any condition where prosthetic valves are there are 2 important things that you got to remember in this particular questions. Question 6 is again a very, very commonly asked question. It's a dental practical question you should know. Patient with prosthetic cardiac valve, now you understood that we have to give prophylaxis. Which of the following regime is a pre-medication as amoxicillin to be given? What the dose? Okay, lovely question. It is 2 gram 1 hour before surgery, antibiotic regimen for dental procedure, single dose 60 minutes before the procedure. The question should be in your fingertips. Don't forget this. So this is a slide. This is a slide. This should be in your fingertips. You are bound to get one question from this particular slide. Although dose for adult and children is given, children, I'm just cutting it. You may not, they are not going to ask you. They are definitely going to ask you about this particular thing. Oral 2 hour, okay, 2 gram, and ampicillin 2 gram IM or IV, or we can give cefazolin or ceftriaxone. They are for those who can take orally, those who are not taken to orally, and allergic to penicillin, then we can give cephalexin, clindamycin or azithromycin. Okay, and allergic to penicillin or unable to take orally, then we can give cefazolin and clindamycin. All are given. This is usually 1 hour before the surgery. So you should know the drug allergic to penicillin or not, oral or parenteral. This much you should know very well, and they are all given just 1 hour before the surgery. Question 7, best fluid for factor 8 replacement. Factor 8 is a anti-hemophilic factor. Anti-hemophilic factor. We all know in this the clotting is defective. That's why clotting time is increased, but bleeding time is normal. Now, what the best thing that we can give? Definitely any source, which is a good source of factor 8 cryoprecipitate. In the absence of factor 8, cryoprecipitate may be used in hemophilic because factor 8 is a very good source of factor 8. We can also give desmopressin, which causes the release of factor 8 from its store in the endothelial tissues, endothelial cells. One more thing, extra knowledge for you, physiology question. All clotting factors are synthesized in the liver. Okay, except factor 8, it is synthesized in the endothelium of the whole body. So a very beautiful question, except factor 8, all clotting factors are synthesized in the liver. Question 8, in the patient with RH incompatibility, which of these will not be there? Well, if I talk about RH incompatibility, so before we discuss the option, this is the blood vessel and this RBC is broken down in the blood circulation itself and HB will be released. This is what is going to happen. So we are going to have a type of intravascular hemolysis. Intravascular hemolysis. And it is this molecule which is going to give rise to bilirubin. Okay, so now we see the answer. Answer is increased bilirubin in the urine. Why this is the answer? Again, we go back to basics. This bilirubin what is getting produced from hemoglobin, it is unconjugated bilirubin. Unconjugated bilirubin, what I'm going to write as UB. It immediately gets attached to albumin. And since it is attached to albumin, it's not filtered in urine. Of course, it will go to the, later on, it's going to the liver where it will be conjugated. Okay. So when it is conjugated, now it is not attached to albumin. It's free. It's free. It can be filtered in urine, but not the unconjugated. So increased bilirubin will not be a feature. Okay. And then we have increased urobilinogen in the urine. Yes, this bilirubin will get changed into conjugate bilirubin will make urobilinogen and stercobilinogen. And free bilirubin, yes, it will increase. Why? Because it is unconjugated bilirubin is getting made. But one thing is very sure, bilirubin will never be there in the urine because it is attached to albumin. So I'm sure you are clear about the basic concept. All the disease showed delayed hemostasis except. Well, it's a beautiful question. Now, again, if you think about delayed hemostasis means any problem in the clotting mechanism or problem in the platelet plug formation. P for platelet plug formation. Patient on ibuprofen, yes, aspirin is a NSAID, it will hamper in the plug formation. Platelet plug formation, just like aspirin. Aspirin is an antiplatelet drug. Von Willebrand disease, definitely it involved in both platelet plug as well as clotting formation. Christmas disease, factor 9, again it hamper the clotting. Thalassemia is the one which has nothing to do with the clotting or plug formation. It's more of a type of hemolytic anemia. So the best answer of this is thalassemia. Okay. So this what I discussed earlier is again, if you want to read more, it is given for your reference to, even you can stop the video to read. More detail, the point I mentioned in the slide discussion, Christmas disease, and finally thalassemia, which is problem of the globin chain, nothing to do with the clotting mechanism. How will you differentiate nasal discharge from CSF? Okay. Answer is beta-2 transferrin. Beta-2 transferrin assay is a highly sensitive and specific test in the presence of CSF in the body fluid. It has been employed successfully by ENT specialists to diagnose skull-based CSF leakage, which is very common in any skull-based fracture. Okay. Now let's talk a little bit more about CSF. CSF lies in the subarachnoid space between the arachnoid matter and pia mater, and the ventricular system around and inside the brain and spinal cord. It is produced by specialized ependymal cell in the choroid plexus. Don't forget choroid plexus. Okay, and absorb in arachnoid granulation. And this drain into superior sagittal sinus. Okay, so being produced by choroid plexus drained out by arachnoid granulation into the superior sagittal sinus. This is how the circulation is maintained. Excess saliva and esophageal ulcer are a feature of which the following condition? Well, the answer is GERD, which full form is gastro esophageal reflux. What is this? Let's talk basic concept. So gastroesophageal reflux, of course, everything is written there, but let me explain to you what is this. When you know the basic concept, then you can very well easily understand each and every word written here. So first I discuss and again come back to this slide, and there are a few more things which are written here also. Okay, so let us discuss the basic concept. The basic concept goes like this. This is the lower end of esophagus. This is stomach, and this is the esophageal sphincter, lower esophageal sphincter, or some people write as lower esophageal. Some people write EO esophageal, some people write OE esophageal sphincter. Lower esophageal sphincter. It is a physiological sphincter. It remains closed normally, but when we eat food, it will open and the food will enter, and again it gets closed. If I have to tell you a day-to-day example, at time you enter a room, door open, there's a door closer is there. Okay, room is closed, and you push, enter the room, you leave the door again, go back, get closed, because the door closer, which is attached to the door. So this is just like, and that purpose of door closers is to keep the door closed all the time. This is like this only, it remains closed all the time. But in certain diseases, this may remain open, especially like in severe obesity, pregnancy, smokers, heavy alcoholic. Of course, list is huge, but there are few important causes. Now, this acid, which is there here in the stomach, of course, we all know stomach has hydrochloric acid. It will come back. It will start coming to the esophagus because this door closer is not working. Now, what will happen? Let's see what will happen pathologically. This lining is normal lining is squamous cell lining. This is normal lining. But when the acid come again and again, this lining, well, normally it was like squamous cell lining. Now it become columnar lining. Squamous cell, columnar lining. The advantage of columnar lining, these cells are big and they prevent the damage to the lower end of esophagus. The cells become more like a cell of the intestine. Intestinal cells are columnar cells. Still later on, more and more, this will start having ulcer formation. So what we call as esophagitis. Patient will have burning sensation, especially after meal or especially after the person eats the food, he goes to the bed immediately, lies supine. So that can lead to burning sensation because acid come again and again. Esophagitis, and later on, this is known as what we discussed about columnar lining. We call it Barrett's esophagus. Barrett's esophagus. And this is a very, very important question. And this can get converted into adenocarcinoma. This is the most important question in GERD. Still later on, acid may come to the mouth. Patient can have sour taste. It can lead to dental damage also. And it can enter the airways. Classically at night, it can lead to nocturnal cough and dyspnea. Any patient having nocturnal cough and dental decay, think about GERD. So this all is written here also. Same thing what I discussed, where you can read it comfortably after stopping the video, but you understood the basic concept. In such cases, treatment is we can give proton pump inhibitor or we can give H2 receptor antagonist. Not a very popular drug nowadays. We primarily use PPI, and there can be B12 iron deficiency. And so in such cases, we may have to replace B12 folic acid. And they are prone to Clostridium difficile colitis can happen in a long-standing cases where we are treating the case of GERD with pantoprazole. Question number 12, ECG S wave represent what? It's a beautiful question. It represents deep polarization of the ventricle. P wave, this is the P wave. This indicates atrial depolarization. This is electrically. What happened mechanically during this time? Atria contracts. Then we have a QRS complex. This is QRS complex. This indicates ventricle depolarization. That means ventricle is contracting. Ventricle contracting. This one will happen mechanically. Small Q wave correspond to depolarization of the interventricular septum. Septa getting depolarized. This can also be seen in old MI also, but that is a very deep Q wave. Deep Q wave seen in MI. R wave reflects depolarization of the main mass of the ventricle, hence it is the largest wave. S wave, final depolarized ventricle at the base of the heart, that's why it is usually a small wave. T wave represents ventricular repolarization. Repolarization means mechanically it will be relaxing. And definitely when ventricle relaxing or diastole, then aortic valve closes. But what about atrial repolarization? There is no separate wave for atrial repolarization. It merges with the QRS complex. Question 13, severe dehydration of a child that is not seen as a sign is, which of the following sign is not seen? In other words, all are seen except which sign is not seen? The answer is puffiness in the eyes is not seen in severe dehydration. So if we have to, in a pediatric child, we have to assess severe dehydration, lethargic or unconscious. Sunken eyes, not puffy eyes. not able to drink or drinking poorly, skin pinch goes back very slowly. They are the features of dehydration. Puffiness is usually the sign of overhydration. So this is not a feature. What are the biggest disadvantage of device shown in the image below? Well, it is everybody knows it is a device so-called for asthma. Okay, so what is the advantage? It's so the question is disadvantage that we are getting it. Well, it's a meter dose inhaler. It's a good also, bad also, something very interesting. So we can give a specified dose in a spray method, convenient handheld device, okay, because we use nebulizer. Nebulizer, that is big machine, we can't carry. That has to use inside or in the near the bed only. But the thing is, in this case, when we are using this, it has to be properly coordinated with deep inspiration, which many patients are not able to learn. That means, like they are pushing, just inhaling. Drug goes, the same time patient should take a deep breath also. Okay, but at times they are not able to do it, and that's why the most of the drugs, they remain in the oral route only, they remain in the oropharynx. Well, efficacy of aerosol drug depend on particle size. It should be between 1 to 5 micron. Otherwise, it will be just remain in the oropharyngeal place only. It will not go deep into. Largest particle, they settle in oropharynx. Only fine particle are then can go inside. In fact, only 4 to 10% reach the correct site. Only 5%, 6%. 95% goes waste. And a part may be swallowed also, which will have systemic effect, which we don't want at all. So in that case, to reduce systemic side effect and low bioavailability, so we can use spacer device. Okay, spacer device we can use, that will have better delivery. Central venous catheter are used for what? Options are given. This is the latest pattern of question is there. You should be fully familiar. INI-CET, they're asking like this only. They want your basic concept should be very, very clear. So if you look into this, the answer this is all. Now my suggestion to you, when you get a question like this, you go by rule out technique. Okay, let's see. Central venous, we put a catheter in the jugular vein or subclavian vein. What for? Do we use monitoring cardiac filling pressure? Yes, it's a very important indication. Rapid admission of fluid, yes, when we need the fluid very fast in a shock, severe shock condition. And in severe shock condition, even peripheral veins are at times not able to assess, then you go for central vein. TPN is the ideal place. TPN stands for total parenteral nutrition. That means you want to give nutrition. Ready-made nutrition, we can give IV, we call as TPN, total parenteral nutrition. Pulmonary artery catheter and pacemaker wire, we only go by the central veins. And aspiration of air embolism, we can do it. So now we have done it, rule out that we are using in all. The best answer is rule out technique we use in all. Okay, same thing. What I told you, given written also, if you want to read more, you can stop the video, read the content. Well, this is all for today's discussion. If you have any problem, you can very well ask to us. We are approachable to you. All the details are given here. And thank you very much for watching this video. Success is not final. Failure is not fatal. It's the courage to continue that counts. That is, Winston Churchill has said it, but I know you will get success because I know I'm teaching the most brilliant minds in our institute, our society, and we all are in DBMCI are proud of you. Okay? So finally, thank you very much for joining us. I hope you like this session. Bye-bye.